During the placement of the line, any assistant or observer should feel empowered to halt the procedure if there is a break in sterile technique. Confirm the needle insertion site again. Generally, it is at the apex of the triangle, just lateral to the carotid pulse. During needle puncture, palpation of the carotid artery can be maintained with the non-dominant hand. In a patient who is awake or minimally sedated, the skin should be infiltrated with a local anesthetic, such as 1% lidocaine, with a 25-gauge needle to help minimize pain on insertion of the catheter. Using the insertion needle, approach the site at a 45-degree angle from the coronal plane, with the long axis of the needle directed toward the ipsilateral nipple. Puncture the skin at the apex of the triangle at the medial border of the sternal head of the sternocleidomastoid muscle, entering just lateral to the carotid pulse. Advance the needle while applying gentle suction to the syringe. Continue to aim toward the ipsilateral nipple at a 45-degree angle to the skin, avoiding penetration into the deep tissues of the neck. Typically, the vein is accessed at a depth of less than 1/2 inch, or 1.3 centimeters. When using ultrasonography, watch for the shadow of the needle to appear on the image. The needle can then be followed into the vessel with ultrasonographic guidance. When the internal jugular vein is entered, a flash of venous blood is obtained. Because of the collapsibility of the vein, this commonly occurs while the needle is being withdrawn, which tents the vein. Once the needle has entered the vessel and steady blood return has been obtained, maintain a steady position of the needle with the non-dominant hand while gently removing the syringe. Dark, non-pulsatile flow confirms access to the vein. Once the needle is in the vein and free flow of blood has been obtained, employ the introducer. Using the introducer, advance the curved end of the guide wire through the needle. An assistant should watch the monitor, looking for signs of arrhythmia during advancement of the guide wire. Arrhythmias indicate that the wire has reached the heart. If arrhythmias occur, withdraw the wire slightly until they cease. After the guide wire has been inserted, withdraw the needle, leaving the guide wire in place. As the needle exits the skin, be sure to grasp the guide wire at the skin. At this point, only the wire remains in place. Using an 11-blade scalpel, make a small superficial incision at the entry point of the wire to facilitate passage of the dilator through the skin. Be careful not to cut the wire. Place the dilator over the guide wire, being certain to maintain control of the wire at all times in order to prevent a wire embolism, and advance the dilator 1 to 2 centimeters by holding it close to the tip and rotating it. Be careful not to introduce a bend or kink in the guide wire. Remove the dilator, anticipating increased bleeding. Maintain a grasp on the wire. A 4x4 gauze pad can be applied to the insertion site to minimize blood loss. Once again, only the wire remains in place. Now, feed the catheter over the guide wire, being certain to maintain control of the external end of the wire before advancing the catheter through the skin. This usually requires that the wire be pulled slightly out of the patient until the external end of the wire extends out of the catheter hub and can be grasped. While grasping the external end of the guide wire, advance the catheter over the wire using a rotating motion. If resistance is met, the track may not have been adequately dilated. Remove the catheter and try again to insert the dilator. Insert the catheter to a depth that places the tip at the junction of the superior vena cava and the right atrium. Remove the guide wire and check for blood return in all ports. Flush all ports, place caps on the hubs, and secure the line in place. Apply a sterile dressing. Obtain a chest X-ray to assess for proper placement and to assure that no hemothorax or pneumothorax has occurred. All sharps should be properly disposed in approved sharps containers. Scalpels should be retracted into their protective sleeves. Needle stick injury can be minimized by using needle lock devices found in most commercial central line kits.